Hello, everyone. I'm Rosalie Harden. I'm the executive producer of Faith and Finance, and I want to welcome you to our webinar today on the church and healthcare and asking some questions about whether the church might have lost its way in taking care of God's people and their health. Before we get started, I just wanted to tell you a couple of things quickly about things that are coming up for us, and we'll be able to send you more information about it and if you join our newsletter. But two events that we're going to be having coming up on October the 8th, more than a webinar, a small seminar with several panels on church economics and talking about the financial crisis in the church right now and how that may or may not, but we suspect is connected to a loss of focus on mission, and how can we get back to being a church focused on mission and solve economic issues that keep us afloat as well. Then that will be leading into its partner event, which is going to be on November the 17th, 2 weeks after the election. Hopefully we will know who the new president is at that time. But regardless, 2 weeks after this election, there's going to be a lot to talk about what's happening in our neighborhoods and what's the role of the church in the neighborhood. So this event, Neighborhood Economics, will be talking about what is the role of the church in the economics of the neighborhood in which it's in and in the economics of the world. So we hope you'll join us for those. And today we're having this conversation about the church and healthcare. And at this moment, I wish that I were going to be introducing you to the person who was supposed to moderate this, Dr. Greg Jones, who is Dean of Duke Divinity, but some urgent extenuating circumstances meant that he cannot be with us here today. And so I'm going to be moderating this. So I hope you will also have a bit of patience for me and also help me out by sending questions in our chat thread to ask of our participants. But I'm pretty excited about this conversation and think we're going to have a good time in this next hour, maybe hour and 15 minutes. So we have almost 100 folks with us today, and we are excited about that, and welcome to all of you. The first person I do want to welcome to join the screen with me is Sister Simone Campbell. And I would be a bit surprised if you have not heard her name before. She has served as the executive director of the Network Lobby for Catholic Social Justice since 2004. She lobbies on issues about how to mend the gap in income and wealth in the United States, which is exactly what Faith and Finance is about. During the 2010 congressional debate about healthcare reform, she wrote the famous Nuns Letter supporting the reform bill and organized 59 leaders of Catholic sisters and their religious leaders, the conference of all of the religious, to sign on. And many people give that letter substantive credit for getting the Affordable Care Act passed. So thank you for that, Sister Simone, and welcome to this Faith and Finance conversation about healthcare.
Well, thanks so much, Rosalie. I've really been looking forward to this conversation. It's a great one.
Well, tell us a little bit about your work and how you see the church and healthcare and money connected. What does that look like from your perch?
Well, I think we kind of have to start with a bit of a historical perspective. I mean, we're in the midst of the COVID pandemic. And one of the articles that ran early on in the Washington Post earlier this year was about how Catholic sisters nursed those who were sick in the 1917 pandemic, the flu pandemic. And that so many sisters actually died because of nursing those who were so vulnerable, who were ill with the virus at that time. But what it lifted up was the critical role that Catholic sisters played in the care of patients and of trying to take care of families that were left orphaned or ill children. And there was a lot of activity on the part of Catholic sisters that I know about that followed that. And then going back even further in the Civil War, on both sides of the North and the South, Catholic sisters were engaged on the battlefields caring for the wounded soldiers. So historically, faith has been, really a dominant factor. I mean, in our Catholic tradition, it's, Jesus said, to heal the sick, blessed are you. So, we responded that way. But what has happened over time is been the shift from it being the Catholic health systems that were created by Catholic sisters. There's the Lutheran health system, various health systems around the country, including the Jewish health system up in the Northeast, that were very effective. But as I like to say, as sisters got fewer, the guys figured out they could make money this way. And it kind of took over the administration. And the shocking thing is at this point is that CEO pay often dramatically outstrips the pay for those who do the most menial tasks, but important tasks in the medical setting. And so one of the tensions that we have is the tension between that instinct to respond to the gospel of care and the fact that the business economic drivers that people found they could make money have now pulled so much money out that the costs are becoming prohibitive for most people to afford. And as one CEO told me one time, he goes, "Oh, Sister Simone," because I was ragging him about how much he was making. It just been advertised, he's making several $1 million as a CEO of a health system. I think it was like maybe 13 million per year, plus benefits. It's like, excuse me. So I said, well, couldn't you just take a cut? Is it, you can't get by on maybe just $1 million less? And he said, oh, no, it's not about the money. I go, what? No. What it is about is that money is the measure of winning. And if I get paid more, then it's the sign that we're the best health system in the nation. And I'll be damned if I'll do a better job for our system and be paid less than my competitor. So it's that competition for being the best as measured by money. And it's the medical model currently that is in this business system. It's not in the response. That we take care of people. Yeah, we respond to people's needs. Yes, we have some amazing cutting edge work going on, but it's not about responding to the gospel.
I'm actually kind of slack-jawed hearing that story.
Isn't it? Isn't it something?
It's stunningly horrendous. How did we move from, first of all, I think it's what Jesus was pointing us to over and over and over in the Gospels in terms of his response to the economics around him in first century Palestine. But when we claim to follow him, how have we moved from a way of valuing our worth, which is the number of zeros in a paycheck for somebody running a hospital, rather than measuring that worth with outcomes, treatment? What could $1 million do to change outcomes that a person could point to? How did that shift happen?
Well, I think part of the dynamic occurred because our nation got so wealthy. And from my interpretation of it, it's about our individualism, and that we do not see the way we're woven together. And one of the things I've hoped from the COVID-19 reality is for us to know that we're in this together, that we're all connected. My wearing a mask out in public and you're wearing a mask is for the benefit of all. Yeah. And to have a greater sense of the common good, feeding the hungry, loaves and fish, we're to care for everyone. So I think that only in a wealthy nation like ours can we be so individualistic and think of healthcare as an individual receiving an individual benefit, as opposed to the communal reality that it benefits the whole community. It's
really, again, breathtaking to to see some of the conversation that's going on in the public sphere where people are very proud of not wearing a mask, where you have people very proud of making millions of dollars and people very proud of not wearing a mask and not being able to make that connection. How has your work and the work with the Society of the Religious called on people? How have you gotten that into the public conversation? What are things that you think are successful?
Well, I think the key for me has been storytelling and being willing to talk about the people that I've met. And because when I lobby, we lobby on Capitol Hill. So, but when I lobby offices, then I could talk about the low-wage worker who doesn't have health benefits, but doesn't qualify through employment, but doesn't qualify for Medicaid coverage, even in an expansion state, because just making a little, more, and that they're using all of their salary to pay rent. And the fact of the dislocation that's happening because people don't have access to what we call living wages. And one of the things we lobby for is the earned income tax credit and the child tax credit, which is a tax benefit that comes from the federal government that goes through your annual tax return. And it goes to low-income families to try to give them a little more than what they're making in salaries. But the thing, and some of the lobby visits that we have, is some members of Congress say, well, that's really subsidizing the people. Well, we shouldn't care for the people. That's encouraging laziness. They're working full time. But the piece that I've come to realize is that the earned income tax credit and the child tax credit are really business subsidies, because business is not paying the full cost of production. And the whole principle of the market is that business pays for the costs it takes to provide a service and charges a fee that makes that possible. But with the skewed salary structures and with the subsidizing folks at the bottom, then what happens is that the money keeps shifting more and more to the top, and we keep working and trying to make sure that our people can eat. Families working, where both parents are working full time. It just breaks my heart. But of course,
astounding.
We couldn't raise minimum wage from $7.25 an hour. $7.25 an hour. Do you know? Oh, you probably know, Rosalie, because you do this stuff. But I don't know if our audience does that. If minimum wage had kept pace with inflation, just inflation, that right now minimum wage would be at $22 an hour to have the same purchasing power that it originally did in 1960. $22 an hour. And where is it? $7.25. That's immoral in my book. It is immoral.
That is immoral. So I want to go back for just a moment. Your work 10 years ago in the conversation about the Affordable Care Act. Can you reflect on the 10 years since that passed, and what did you ever think it would pass? And now, how do you feel about?
Oh my God.
What's happened since
Did I think it would pass? I was holding my breath. I mean, the reason I wrote the Nuns letter was that we were desperate. We were desperate. And I knew the only way to improve our health system. I mean, people forget, as a small business, we were being priced out of being able to provide health care for our employees. That costs were rising so quickly. There was no curb on it. And we had a couple of staff with pre-existing conditions, and they were excluded from coverage. And I mean, all this horrible stuff was going on, and it had to be fixed. And so we were urgent about it. And I didn't know, okay, and being a person of faith, I love being on this call because I can talk about my faith in here, is that the thing that came to me in my meditation was, who knows healthcare? Our sisters do. They lead health systems. So get the sisters to sign a letter. And so that's how that happened. I mean, for me, it was the spirit alive in the moment. And then it was gift. But what has happened since then, it's become such a partisan piece that
Right.
people get healthcare, that it's not about getting healthcare to people, it's about the political game. And that breaks my heart. It breaks my heart because we need to improve the Affordable Care Act. It's not the end all and be all, but we spend all our time fighting the partisan fight, not talking about what our people need. How about how do we get them care? Like we were up in last year, we were up in Amsterdam, New York, at St. Mary's Hospital up there, and this hospital in the Ascension Health System. Okay, it's a faith-based organization. They've provided through their creativity all kinds of ancillary services because there is nothing in their rural community. So they've got a food distribution where doctors, if you've got diabetes, doctors can prescribe some food and you can pick it up, and they've got a Medicaid waiver so they can get some money for it. They've got in-home supportive services so that you can get counseling or physical therapy out in your rural community because transportation is impossible. But it's the economics of it are breaking them, but they're so committed to the community that they're doing everything they can to make it work. And that's the quality of faith-based engagement in a community, but the undermining of the financial structures that allow it to work. Because they've got a big old hospital they need to remodel and rehab, and oh my God, the heater went out. It was wintertime and it's cold in upstate New York, and the heater went out while we were having our meeting. They said, well, yeah, we got trouble with our boiler. It'll kick back in a little while. We want to get it fixed, but we don't have the money.
Sister Simone, this is really kind of humorous because one of the things that we've been talking about as we've been getting ready for this webinar was we were imagining that it was going to be hard to keep the quality of the conversation focused on money. We had no idea what you were going to be saying. It is about money. It is about money. It is about money.
It's totally about money. And the current business model for the delivery of health care in our nation is unsustainable. It is unsustainable because what's required to make the margins that the various systems need is you need high volume, you need a dense population that can access these big specialty health clinics. We were up in Wabasha, Minnesota, which is about an hour and a half from Mayo Clinic. And they were talking about how the Mayo Clinic is destination medicine. But what they're about, St. Elizabeth's, their 25-bed hospital and their little nursing home and their home health care services, they're about the whole person, about delivery of healthcare to the whole person. And the Mayo Clinic gets all the headlines, and people travel from all over. And the city of Rochester is trying to create entertainment options for families that come with patients to the Mayo Clinic, so they have something to do while they're at Mayo. Whereas here are these people with their little hospital and trying to serve this aging farming population, and the efforts at being present, and the fact they don't have good access to the internet, so it's hard for them to do home health nursing out in the rural communities because they can't access patient records. And the CEO of the hospital is really worried because of the aging population. He employs, as I recall, 400 people from this rural community, but over half of them are over 50. And what's going to happen to his workforce?
Right. Yeah. Well, I want to pause for a moment and invite 3 practitioners, people who are out in the field working on this in their own way, to join this conversation. First of all, Sarah Thebarge, who is an author and a health practitioner. And she is the author of Invisible Girls and a book called Well, and works as a physician's assistant. And she will be joining us from San Francisco, where she works in the emergency room at San Francisco General. And Dr. Samuel Ross, who is the Chief Community Health Officer, who I can't imagine that Sister Simone has said anything that's of interest to you, Sam, because working in a Catholic system, listening to her passion about what it is that y'all do in that system. And then the Reverend Dr. Scott Morris, who I was curious, Scott, did you get your MDiv first or your MD first?
I went to seminary first and went to medical school. I think of myself as a pastor who acquired a particular skill.
So Scott's a pastor in the United Methodist Church and a physician, as you hear, and founded an amazing work in Memphis, Tennessee called Church Health, as you can see there in the background of his picture. I want to start with you. If you could tell us a little bit about how you see some of the things that Sister Simone was talking about there on the ground in Memphis, and what has your response at Church Health in Memphis been to that?
Yes, I'd like to just add a little bit to the history here, because I think it is reflective, particularly from the church's perspective of how we are in the mess we're in. So, prior to the Civil War, if you were sick, the most likely person anybody would have seen for healthcare was actually a pastor. A pastor provided virtually all the healthcare in this country. Now, at the end of the 19th century, there was an explosion in medical science. Prior to that, there were a lot of folk remedies. John Wesley, the founder of Methodist Church, actually had 19 different cures for baldness, most of which I tried myself.
Very effective, very effective.
My favorite is you take a big red onion, you cut it in half, you rub it on your head until it turns red, and then you put honey on it. Anyway, that never worked for me. But in the late 19th century, there's an explosion in medical science, which along with it arises a new profession known as medicine. It is seen as to be financially lucrative. It makes sense to keep the clergy out. And the truth is the clergy are too lazy to keep up with all the new knowledge. So with this, in the beginning of the 20th century, with this new knowledge, the social gospel movement led by Walter Rauschenbusch pushes the church to argue all this new knowledge should be available for everybody, including the poor. So all over this country, we build hospitals that have church names on them. Mm-hmm. Here in Memphis, it's Methodist and Baptist. We also have St. Francis. We used to have St. Joseph. But these hospitals are all built between 1900 and 1930 with the primary goal is to make the access to this new knowledge available to the poor. Now, wealthy people are more than willing to let the church support these new hospitals, but they want to keep their care to themselves. And so the doctor will come visit them, making home visits. That works that way until the 1930s. Rich people look at the data and realize people actually do better in the hospitals. And so they change the formula and tell the church, we will run your hospitals for you as long as you keep funding them. The church agrees to that. That continues until after World War II, that there's a real new advent of health insurance, which really didn't exist before. And then the hospitals, however, though, are struggling financially. And the hospitals turn to the church and say, we need more money. The church then, however, builds a firewall financially between the church and the hospital and tells the hospitals they have to financially fund these things on their own. It works that way because now there's a new profession created, that of hospital administrators, but the ones that Sister Simone was talking about. Early on, they didn't get paid like that, but they were given the charge to financially make the hospitals work. They struggle mightily until 1965, they're given a gift from God, the advent of Medicare and Medicaid, at which point the hospitals are now making money hand over fist. They are putting money into closets. The church then comes back to the hospital and says, hey guys, remember, we own you. We want to share in your wealth, but the hospitals have a firewall that was built by the church to prevent that from happening. At which point the hospitals now create their own sense of financial largesse. But in the 1980s, a new phenomena is created, which is for-profit hospitals. And these for-profit hospitals compete with the church-owned hospitals. And as a result of that financial competition, you ultimately get to where we are today, where you could argue that the church-owned hospitals do 100% more charity care than the for-profit hospitals, and you would be right. If you were slightly cynical, you might ask the question, because these are the national numbers, is there really that much difference between 2% and 1%? So what I ask the question is, how did this happen? How did the church let it happen that these hospitals were built for the sole purpose of providing health care for the poor, until where now the poor are lucky to receive their care in church-owned hospitals? So in Memphis, you know, I moved to Memphis. I'm not from Memphis, because I read somewhere that Memphis was the poorest major city in America. I came here literally not knowing a soul, totally selling out of an empty cart, to create Church Health, which provides health care for people who work in low-wage jobs who don't have health insurance. That's our niche. And so we exist in order to engage the church to do what we're called to do. You know, a third of the New Testament has to do with healing the sick. It is on every page. You know, you don't get to take a pass on the healing part. You know, if you want to follow Jesus, you're expected to preach, teach, and heal. You know, do any of us want to, at the end of time, look God in the face and say, and have God say to us, did you think I was kidding about that part? So that's our mission, and I fully believe this is the mission for the church in every turn. We just forgotten
it. You are as passionate as Sister Simone is. And you moved to Memphis because it was, at that time, the poorest metropolitan area. And can you give us just a quick little statistical look at what Church Health is doing? And then, Sam, I'm going to be coming to you next to talk about community health and what you're doing at Bon Secours and across that and Mercy. So, but first, if we can just get just a quick statistic from Scott.
So we began in 1987. We saw 12 people the first day we were open. That's the fewest we've ever seen. There are currently 70,000 people in Memphis who depend on us for their health care. So we're a true charity. We're not a federally funded anything. So we're not an FQHC. Our mission is to provide health care for the people who work to make our lives comfortable. They cook our meals, they take care of our children, they wash our dishes, they'll one day dig our graves, they don't complain. Yet when they get sick, their options are very few. So Tennessee, Mississippi, virtually every state in the South, we have chosen not to expand Medicaid through the Affordable Care Act. It's, you know, through the wisdom of the Supreme Court, that they let that happen state by state. And so in Memphis, we have, well over 130,000 people who are in this category, working and uninsured. And that, if you make below 138% of the poverty level, which is roughly $12 an hour for a family of four, you can't buy insurance on the exchange because it is assumed that you would qualify for Medicaid. So if you are making $12 an hour, so of our 70,000 people, 90% of them fall below 138% of the poverty level. When during open enrollment and they go to healthcare.gov and put their income information in, you know what it says to them? It says you should pursue Medicaid in your state. Only Tennessee didn't expand Medicaid. So what that means is the poorest people get nothing.
Amen.
So the impact of the Affordable Care Act on poor people in Memphis has effectively been nothing. And had repeal and replace happened, the impact would have been nothing. No, Jesus
On
said,
Tennessee,
"Will always
on
be
Tennessee,
with you."
St. Scott, you
But
can't leave it there. It would have been nothing for your people in Tennessee.
I'm in Tennessee.
The
That's
rest
right.
of the
You're right.
nation,
Nothing for
the
us in
rest of the,
Tennessee. That's what I
the
focus
rest
on.
of the nation would have been devastated.
I'm
There's
with you
13
about that,
states,
Sister
13
Simone.
states in your situation, but it's
I'm
because of state policy, not because of the ACA. Let's be clear.
okay. I'm with you're totally right there. But I guess the point for me is that Jesus said the poor will always be with you. So far, he's been right. I just don't think he ever thought there were going to be so many poor people.
Mm. Thank you, Scott. Now we're going to turn to Dr. Samuel Ross, who was and I is still, I bet, a family physician, but has been working at Bon Secours and now merged with Mercy Health and is the chief community health officer. Did I say that correctly?
That is correct.
So what is it that you do, and what is it that health system that is still impacted and influenced by a bunch of sisters, I understand?
Yeah, and when I mentioned that I was going to be on a panel with Sister Simone, they were like, "Oh, great, she's wonderful." Oh, and so Sister Pat Eck
Oh, yes, yes,
others
we're friends, yes.
certainly said, "Please do that and be on that panel with her." So I'm fortunate enough to work for Catholic Healthcare, even though I'm Baptist by training, and I've shared before that now I feel like I'm a combination of Baptist and Catholic, so I'm Baptolic in my religious affiliation. But the current Bon Secours Mercy Health is the Sisters of Bon Secours, the Sisters of Mercy in Ohio, and the Sisters of Humility of Mary. Those are the three orders that make up our ministry. And we're fortunate enough that, you know, in my time, Bon Secours Mercy has been about 14 years now. I relocated from Texas. You know, Scott says he went to Memphis. Well, I went from Texas to Baltimore, Maryland, in Southwest Baltimore, which was our smallest hospital and really our most disparate around health inequities as it related to income in that community, social determinants all around. And I've been fortunate to work in Catholic healthcare because I think when you talk about faith and finances, what I have experienced is that, at least in our ministry, we've been consistent around making sure that we follow our faith, we follow our beliefs. Someone at one of our sessions a few years ago, they asked the question, "What are you grateful for? What are you most grateful for?" And so when it was my turn to speak, I said, I'm grateful that in my first year at Bon Secours, Baltimore, we lost $15 million from budget. And I was scratching my head because I came from Parkland Hampton Hospital System. We're government funded, a lot of it, but we never had a negative bottom line. And so I always said when I was called to Baltimore, and I said, I really feel like I was called to Baltimore. And that first year, losing $15 million in budget, you know, it's like a head scratcher. And then I say my second year, I was blessed to lose $20 million from budget. And at that point, I was saying, Lord, was I called or was I hallucinating? Because this just didn't seem right. It didn't seem to be going in the right direction. But, you know, starting in the third year, you know, with support both from our organization and also other stakeholders in the community and also even at the state level, we were able to turn that thing around. But I said I was most grateful because I could lose that much money from budget and still be gainfully employed. And there's not many organizations, certainly on the for-profit side, but even in the nonprofit world, that people can say that. But I can say that our commitment has been to truly addressing, Sister Ann always says, what do the people need? And so our community health division really is about understanding, you know, the Affordable Care Act requires us to do the community health needs assessments. It requires us to document community benefit. But beyond community benefit, what I keep saying to our folks is that if we're going to do community health, population health, whatever the term you want to use, it's understanding that community benefit is something that we're required to do to maintain our nonprofit status. It's the IRS guideline. It's a lot about subsidized care, for the reasons that we all know. Medicare doesn't pay enough, Medicaid doesn't pay enough. But beyond community benefit, we have to look at what is our community investments in what we're doing around addressing social determinants. So when I hear the work that Scott's doing in particular, and the things that you, sister, are talking about, there are community investments that go beyond, IRS requirements. And when we start talking about charity care, again, what are those direct dollars that are either coming out of operations or coming out of our foundations that are going into programs and services that address those needs? So community health, using the community health needs assessment as our foundation, we identify what the community says are their priorities, what the community says are their needs. And the thing in Baltimore that most people know in Baltimore, we got into affordable housing back in the 90s. And we now own and operate over 800 affordable apartment units, both for families and seniors. Well, people say, well, how did Bon Secours Baltimore and Bon Secours get into housing? It was because the community said their primary issue was rats and trash. When you started to look at the root cause for the rats and trash, it was all the vacant, boarded up buildings, because Baltimore used to be a city of 1 million people. It's now a city of a little over 600,000 people. So it wasn't about health care as we traditionally know it. It was meeting the people's needs around affordable housing, which would then address rats and trash. And then we built all of our other programs and services: workforce development, financial literacy, early childhood intervention, returning citizens programs, because the largest percentage of citizens in incarceration in Maryland were coming from our primary and secondary zip codes. So all of these things in community health have been about addressing social needs that are identified and then putting in programs and services that make those things, work and change those outcomes. So when I think about finances and faith, I can say for our organization, that commitment has been there, and that's what's kept me in Catholic healthcare for these years. And I'm blessed, now that we merged last year, we got $20 million that were put into community health for community investment, because one of our planks is under the Healthcare Anchor Network. We're similar to the work that Scott's doing, and I'm very impressed by his work, and we definitely have agreed to follow up after we made this connection, because through the Healthcare Anchor Network, we're committing in our markets where we're anchor institutions that we're going to focus on local inclusive hiring. In our markets where we're anchor institutions, we're going to focus on supply chain sourcing. So how do we use our discretionary dollars to work with women minority businesses such that they can grow and that they can hire more people from the community? And then the third leg of that Healthcare Anchor Network platform is that we're going to do direct community investments. So if the community need is housing, how do we partner with others to do housing? If it's education, how do we partner to do education? If it's the food insecurity issues, how do we partner to do that? So that's been our work in that commitment. And so I'm really blessed to be able to say that, you put your money, where your mouth is, because if we don't, we're no different than any other nonprofit. Catholic Healthcare doesn't distinguish itself, set itself apart in that way. Then you're no different than any other not-for-profit or any other for-profit. And so we have to stay true to that. And sister, I have to say, I don't make 13 million a year. So
I wasn't talking about Bon Secours. Another one that will remain nameless.
No, I'm just joking with you. But I'm happy to be where I am and the commitment that our ministry has made. And let me say something else too, because someone mentioned this earlier about mission, and I'll say formation. One of the things that we have implemented both in Bon Secours and Bon Secours Mercy is that for every employee, and now with physicians being employed, et cetera, formation and mission formation is a key component of all that we do.
Wow.
Because people have to believe in what they're doing, not just be there for a paycheck, or not just be there, because they have no other place to be. So that's a key point for our physicians, for our nursing, for our leaders, for all staff. And I'll stop there.
Well, Sam, I'm going to ask you a follow-up question there, because what you're talking about, faith and that connection between faith and finance and that connection back to the mission, what would you say to pastors and people in the pews about how do we get informed? How do we understand this in a way that we can begin to talk about it in a way that can heal this conversation in our country?
So, Scott's organization touches on this as well. So a lot of our community health work is identifying church leaders as our stakeholders as well.
Mm-hmm.
So we have, faith health programs, congregational health programs in most of our markets. We try to get the ministers involved. We try to get them on advisory boards, et cetera, because it's important for the reasons that you raised, that they understand that they are their brother's keeper and that they are responsible. And I will say, and I think Scott mentioned this too, as a result of the COVID, I have seen church leaders step up. I have, whether it's Catholic, whether it's Baptist, Presbyterian, that they are embracing that obligation to care for their parishioners, their community in a way that they didn't do before. So we are getting more requests from churches because the members rely on the churches. The churches know they have limited resources, and we're creating more partnerships along that line with faith leaders to do that. Because to Simone's question, or her point that she made about others, there are a lot of church leaders that make a lot of money. And they
not me.
regardless of faith, and they need to be looking at what they're doing and demonstrating that behavior equals belief.
Amen.
And that's what we need to see.
Amen.
But this event that I mentioned at the top of the webinar, I started to say top of the show, neighborhood economics that we're doing 2 weeks after the election, we're going to be talking a lot about anchor institutions and how the church can be an anchor institution and how a hospital can be an anchor institution, and what are those institutions that have resources in neighborhoods of need, that and how that flows and how the church can help do that better. So Sam, you can be holding that date for us, because I definitely want you to be a part of that event. We're going to turn now to Sarah Thabarge, who is on the front lines in San Francisco, working as a physician's assistant. Is that the right term, Sarah? Yeah. At San Francisco General. And I'm curious, as a healthcare provider in a public hospital in a city where I lived much of my adult life that has major homeless issues and major issues of poverty, and the San Francisco General emergency room is on the front lines, and you are a person of faith. How does that all connect for you?
Yeah, I mean, for context, SF General is the county hospital. So anybody without health insurance or anybody that has state health insurance has to come to the hospital at SF General. It is also the trauma center. So it's definitely the trenches of healthcare. I think, in my career, I've spent 15 years working mostly in ER centers in the US, but also I've done international medicine in Togo in West Africa, which the UN ranked the least happy country in the world, in South Sudan, which is currently still an active war zone. So I've also been able to put healthcare and suffering into context, and also kind of compare and contrast what happens internationally and what happens in the US. I think we have so many amazing technological advances, pharmaceuticals. We've got a lot of resources to help save lives here in the US. And in a lot of places, they don't have those resources when we're talking about under-resourced countries. What breaks my heart, though, especially being in San Francisco, which is so wealthy, there's so much wealth here. San Francisco is the most expensive real estate market in the country. It costs more to buy a house in San Francisco, or even rent in San Francisco, than even in Manhattan. You need tens of thousands of dollars more a year in salary to be able to afford a house in San Francisco that you could afford in Manhattan. And for all of the wealth that's here, it is stunning to me how much suffering, how much poverty, how many people are going hungry, and how many people don't have the necessities. And it is healthcare, but it's also things that are related to being well and to human flourishing. So, you know, it's one thing to be able to come to the hospital and get your emergency treated. But then, you know, in San Francisco, especially with COVID, they shut the shelters down. And so now when somebody gets discharged from the ER, if they don't have a place to go, a social worker gives them a tent and then they go sleep on the sidewalk, which makes them vulnerable to a whole lot of other health issues and doesn't give them the place that they need to be able to go to recover, to be safe, and to stay healthy. And so while I'm really encouraged by this webinar to see all of the amazing work that the church is doing and has done, what I wonder is, why do we still have the disparity? Why do we still have this discrepancy? When did the church decide, well, now you can get health insurance through your job or you can get it through state aid? And so the church just kind of washed its hands, and we didn't realize that ultimately, if our neighbor's hungry, it doesn't fall to food stamps, it falls to us. Ultimately, if our neighbor doesn't have a roof over their head, it doesn't fall to the government, it falls to us. And I think part of what I see is this question of how does the church reclaim its mission and reclaim its responsibility to truly love our neighbors as we love ourselves in really, really tangible ways. And looking at the ministry of Jesus, what did he do? He fed people and he healed them. And I think if we really are to follow in Jesus's steps, I think, you know, we step up and we take that mission literally and seriously.
Sarah, you really literally took the words out of my mouth. The next question that I had planned to ask y'all was that it seems to me that this should be obvious. I'm curious from any of you, but I'm going to start with Sister Simone. Where do you think, why do you think we're not getting this message in the pulpits and the pews? Why is this thing that seems so obvious to us about the care for the poor and reading Jesus' words about living, I mean, in my words, living wage and how money should be distributed, and his critique of the economics of his day and the health of his day? Why are we missing that?
Well, okay, I'll start. I'd be curious how this is going to fall, but I think it's the reason why we don't hear it is that it's disturbing, and that parish, at least within the Catholic tradition, pastors are sort of charged with trying to keep everything calm. And if you preach the gospel, I mean, you know what happened to Jesus. Well,
right.
Our irony is that we say we follow Jesus, but not that far, okay? So the key is, I think, to be willing to lead conversations that do explorations. Because I've noticed in the chat some people arguing with me about minimum wage and all this other stuff. And I just want to say that the fact is Catholic social teaching in our tradition is that people should be able to live on their wages, on a single job, and have some recreation time with their family, and to save for retirement. That is a basic minimal test in our capitalist system. But to preach that is disturbing.
Yeah.
Because we're so far from it. And Pope Francis has this, among all the, he says a bunch of really great stuff, but one of the things he says is that, you really can't have charity until you have justice. And preaching justice is disturbing.
Yeah. Well, that's interesting that you would bring that up in terms of it's scary. One of the things that I have found in my speaking around the country and talking about faith and finance, when I ask people whether they're clergy or laity, how many times they have either preached a sermon or heard a sermon preached on money, not at stewardship time, but just on money, Zero hands go up from the pews, and occasionally a clergy person will try to tell me they've preached on it. So just a little plug for something that we are doing this month is that starting next week, and you're going to start seeing some posts from us where we have asked 4 or 5 clergy people to actually preach a sermon on money, and we're going to post it and start trying to have a conversation about why people don't preach on money and how to get them to do that. So we may expand that to money and healthcare and get people preaching on that too.
Money
So-
and anything. You got a lot.
Money in anything. Yeah. Yeah.
Get people to preach on dental care because dental care for the poor is one of the most important things that drives their health down. And I'm willing to bet
Wow.
nobody has ever heard a sermon on dental care. But can I just add, my 2 cents on this is that, I personally believe the world is driven by ideas, and I would argue theology in one way or the other. So from a health perspective, but I think also it bleeds over into the economics of this. I 100% blame Descartes. Descartes convinced us that you can take a human being and separate us into a body and a spirit. And what we have done in the healthcare world is we put the body on one side and said it's the purview of science and medicine. We put the spirit on the other and said it was okay for the church to mess around with your spirit, but it should never cross that line and actually care about our bodies. This Cartesian dualism, which is just a recapitulation of Plato, that mindset rules the day. We experience it in virtually everything we do. And it's why within healthcare, doctors cannot take seriously the spiritual dimension to life. No doctor, Sam, did you get an A on the course in spiritual care? No, they never even brought that up. By the same token, in the least healthy meal you can eat every week is at a church. Our churches have blessed the sin of gluttony for the sake of fellowship. In the midst of the obesity epidemic in America, clergy are actually 20% heavier than the rest of the population. So our churches have completely bought in to preaching our spirits in the sweet by and by, even though that is not a biblical concept. And our ability to connect body and spirit, and then I think you could argue to even engage the economic dimension of life is why churches can't, focus on this. It begins with our fundamental view of what it means to be a human being.
Can I add something to, you asked the question why they don't preach about money and probably why they don't preach about dental health, et cetera. I think it's the basic issue of not knowing what to do about it if they do preach about it. Now, what you hear them most often now preach about is mental health because of depression they're seeing among their members because of COVID and loss of jobs, et cetera. So I think the reason that you don't hear them speak about it is that it's uncomfortable. One, because they think it might impact, the tithes and offerings, but also because they don't know what to do about it. And to the point about kind of how we don't treat things holistically, whether the church has compartmentalized us, and certainly in healthcare we have, because I tell our folks all the time, when the person comes into our system, no matter what the entry point, they don't break into, well, this part of my body goes to revenue cycle. This part goes to radiology, and so on and so forth. But we have created this compartmentalization about how we treat people and moving away from the holistic approach. But I think the basic issue is, whether it's in healthcare leaders or in church leaders, is this discomfort. And one of our legacy and leadership sessions, our leader, Father Joe Driscoll, he would say, we have to get comfort in the disequilibrium, was the phrase that he used to use. And that's what we have to move toward, because there's none of this that's easy. As Sarah was saying earlier, the observations that she was making, we find it easier not to deal with it and somehow think that it's being dealt with. And that is the furthest from the truth. So we have to embrace our advocacy role, which we moved away from, and just being honest. If we don't know, we don't know. But how do we work together, create collaborations, partnerships that allow us to address the needs of our people that we've been called to serve?
Sarah, I'm gonna put you on the spot just a little bit, because Sarah and I actually, she is a member of the congregation that I consider myself a member of, St. Gregory of Nyssa in San Francisco. And that's a place where Sarah Miles' work was based when she started the food pantry there. And you were talking about the number of homeless people in San Francisco. And I'm wondering if you could maybe thread some of those conversations together, from what's happening with the food pantry at St. Gregory of Nyssa, in that city of so many homeless people, and your work at the General, and how all that merges together, and focusing in on how do you take your whole self to the emergency room at San Francisco General too? How do you be that spiritual presence in a very secular city?
Sure. Yeah. Then that's all.
Big question. Sorry.
Well, yeah. I mean, I think that especially because of COVID, I think COVID stressed the whole country, and we really, it made it very, very obvious where the weak spots are. And that is true in San Francisco. And so what we realized was the people that often work, there are essential workers. So people that drive buses, people that wash dishes, people that are nannies and house workers, and all of those important but often underpaid, and uninsured jobs are really, really struggling. Partly because they're getting sick because they are on the front line, so they're more exposed, partly because they have underlying health conditions that they haven't been able to get addressed. Maybe they're undocumented, maybe they're working 3 jobs, but none of them has insurance linked to it. And then also there's a lot of food insecurity that's become really apparent. So I often, on Saturday mornings, we partner with the Marin San Francisco Food Bank right now during the pandemic. So our spot hosts it on Saturday mornings. And before COVID hit, they used to give out, I think, like 75 to 100 bags any given week. And now we're over 400. And people are lining up 4, 5, 6 hours before the doors open because they're hungry and they don't know any other way to feed their family. And so partly, I think, for me, when it comes to how did the church get in this spot, and which, once we understand how we got here, we can maybe find a way forward and be informed about that. I think that the problem maybe started or became worse during the 80s when we had the marriage of politics in the church. So we had the moral majority, and people began to believe that if you love God, you have to vote Republican. We picked these knee-jerk political issues. So you say the word homosexuality, you say the word abortion, and people, the definition, the medical definition of a reflex is a response that literally skips your brain. And I think we created this reflex where people partly decided they were going to vote based on 2 issues and not the whole, common good. And then the other thing is that once we decided if we vote for the right candidate, they're going to put all of these governmental policies in place, and now we've outsourced the job. So now they're the one that's responsible for feeding people that are hungry. They're the ones that are responsible for paying the bill when somebody gets sick. And I think when we did that, we really lost the plot. And so I do think that, food stamps are valuable, healthcare that comes through the government or linked to a job, super valuable, but there's so many people that fall through those cracks. And I think it comes back to, if I say I follow Jesus, what do I mean when I say that? And then what do I do because I say that? And what it means for me is literally my literal hands, my literal feet go to those places and do something about it. And it reminds me, as somebody of faith, I grew up in church. My dad's a Baptist minister. I went to all the weddings he officiated, and I heard 1 Corinthians 13 like a zillion times. And it ends, now these three remain: faith, hope, and love. But the greatest of these is love. Never occurred to me to wonder why out of three great things out of faith, out of hope, out of love, why would love be the greatest of great things? And it wasn't until I went to Togo and I was slogging it out in this really difficult situation, running out of water, people dying all the time, that it occurred to me why love is the greatest thing. It's because if we just have faith, then we believe that God is somehow going to perform a miracle and hungry people get fed and sick people get healed and brought back from the dead. If we just have hope, then we do have that mentality of like that sweet by and by. On the other side, when God destroys the earth or raptures us and he recreates the world as it should be, then, that's what we look forward to. But it's love that makes us look around us, see the people that are suffering, and care enough to do something about it. So for me, what I mean when I say that I follow Jesus is I say, I'm going to let God break my heart. I'm going to let God open my eyes, and I'm going to fall in love with the world like Jesus did, enough to be physically present and do something about it.
Can I just add to that, Sarah? That's exquisitely beautiful. And what I talk about a lot is that broken heart. It's that broken-hearted place where all are welcome. Because I know if I'm closed up in my heart, I don't have room for everybody. But if it's broken open, anybody fits. But I think one of the big challenges in healthcare or any of the service sectors is that it's often seen in the faith traditions that it's for the people of that faith. And so many people don't fall within those faith lines that they get left out of care. And we as people of faith may feel that they're welcome, but it goes back to that judgmentalness that you raised earlier, that if you've got a label that's been a knee-jerk reaction, then you're left out of our care. And so some of it is on our part to open our eyes to the fact that God doesn't make mistakes and we welcome all of God's creation. And the other piece is to have backstops and safety nets that can catch those who have had painful, bad, frightening experiences with faith they can't approach. So it's both and. It's not either or. The need is so big that we need everything thrown at this moment.
Yeah.
So I'm going to ask a round of questions to each one of you. And the first one is going to be, what is one thing that you think people can do to help move this conversation forward? Either from the system perspective or from the personal perspective, or both, if you wish. And then the next question is going to be, what in this moment is giving you hope? But we're going to start with, what's something that people can do to make a difference and help the church reconnect with our role in healthcare? Scott, I'm going to start with you.
So, Sister Simone, I would argue that one of the things that the church can do in the states that have not expanded Medicaid, because you're totally right, it is a state-by-state issue, is just somehow or another find a way to connect on that political world to understand that these are our fellow citizens. From our perspective, that they are the people who work to make our lives comfortable. Organizations like Church Health are vital primarily for the church. But a way the church can act around healthcare would be to really find a way for the states that have not expanded Medicaid to finally decide to do it. Truthfully, I'm not holding my breath for Tennessee or for Texas, Sam. So I think that matters. The other thing that I think has to matter is to understand that this issue to preach, teach, and heal is real. And embracing a healing ministry ultimately is about evangelism. The early church grew not because of great preaching. It grew because in the 2nd and 3rd century, there were plagues all over the Roman world. And when people got sick, it was only the Christians who were willing to take care of them. And when they got better, they asked the question, who is your God that I might worship him? That's what grew the church to the point of where Constantine was willing to make the church the state religion of Rome. Now, the church needs to re-envision who we are. COVID has actually given us an opportunity to stop just worrying about how do we fix broken buildings in churches all over this country and figure out how could the church get beyond a broken building and fix broken communities. This to me is an enormous opportunity for the church to actually reimagine what it could be. And I actually think healthcare could be one of those ways to lead us to a new way of being church.
Yes, thank you. I've been really intrigued in some of our pre-calls about this, that COVID has, that y'all have reported to us, to me, that COVID really has gotten the conversation going in a completely different way. And that churches are beginning to see this in a different light. Sam, what do you think we need to do?
Oh, I'm gonna use my Baptist background. My wife always laughs at me because she knows I do this. Because I say I'm the son of a Baptist minister. So I'm gonna make 3 points and pass the collection plate. So one of the sermons that I heard a minister preach was taken from Judges, Book of Judges, chapter 31. And it says Shamgar, it mentions this biblical character, Shamgar. And all it says about Shamgar is that with an ox goad, which is like a plowshare, that he slew 600 Philistines. And the 3 points that the minister took from that passage was start where you are, use what you got, do what you can. So when you think about, one thing that we can do is different for each of us because our circumstances are different. But if we look around, what is it that we have been called to do? And in many cases, is it about a prophetic voice? In other cases, it's about an action. We talk about how do you move things from your head? We talked about heart to your feet, which is the action that we have to go about doing. So I think the one thing that I can do and others can do is figure out, based on where you are, your environment, things around you, what is that action you can take? Is it an individual action because there's someone right around you that has a need that you've been ignoring and needs to be addressed? Or is it becoming a member of some other organization or activity that you can lend your gifts? Because God has given each of us a gift. We may not have all figured out yet what it is, but he's given us one. And so we should be asking and discerning for more knowledge around what that gift is and how we're being called to apply it. And then go about really acting. There's another old phrase that someone says that it is easier to act your way into a new way of thinking than to think your way into a new way of acting. So the one thing we can do is act and figure out for us individually what that means and what that looks like.
Thank you for that, Sam. Richard Rohr, I believe, is one of the people who gets a lot of credit for that. And we've been posting, we have posted, Scott, in our thread that you're going to be interviewing him tomorrow on a webinar. So we're inviting people to join you tomorrow.
2 o'clock. Richard Rohr and I one-on-one on this issue of healthcare.
Great.
Tell him hi from me.
Yeah.
I will.
Thank you.
So Sarah, I'm going to go to you for what is an action and then where do you find the hope?
Yes, I think 2 things. So first of all, when it comes to churches and healthcare and finances, I think we start with looking at the issue of medical debt. So before we can find a way to move forward, I think we have to fix the damage that's been done to people's lives because the church dropped the ball and all these people did fall through the cracks. 66% of bankruptcies filed in the US are from medical debt. And one of the beautiful things, and one of the things that has given me hope, is seeing churches that have done massive fundraising efforts and forgiven the medical debt or paid off the medical debt of the entire community. That to me is beautiful, and I feel like it's also a really practical form of repentance, of making good on what has been done to people because we didn't live out the words of Jesus in a really practical way, like we should have been doing all along. So I think as church communities, I think that is the place you start. And then secondly, I think as individuals, we also look around and do what we can. I read this quote, I can't remember who said it, but they posted it yesterday. The pastor I follow on Twitter, and they said, do for one what you wish you could do for all. So I think you look at, you wish you could forgive millions of dollars of debt. You can't, probably. But when you have a conversation with somebody at church, with a neighbor, when you become aware of a need, you do for that one person what you wish could be done for everybody. And then that takes really practical form. So maybe it's specifically paying for health debts. But the other thing is, my housemates and I, when the pandemic first started and the CDC was like, wash your hands, wash your hands. People that live on the streets don't have running water. They can't wash their hands. So that we have a tree outside our house and we hung a bar of soap. So we did a soap on a rope. My housemate, who's done water projects in the developing world, rigged up a hand washing station. So there's a stick, that's the pedal. There's a gallon of water that tips over and people could just stop at the front of our house and wash their hands. So I think there's really simple, inexpensive things that we'll find all around us if we just open our eyes and we're willing to take tangible action about that.
Amen.
Yeah. So, Scott, can you give us, where are you finding hope?
Well, I mean, if you don't have hope, man, we're lost. I personally find hope in the fact that I like talking to you guys, but I do see patients every day, and but finding, watching people be able to find their path through just enormous angst, and yet they come together, and their faith is what drives them at every turn. People find the way to link arms, to not give up, and at the end of the day, just to focus on what's happening right today, and set aside all the stuff that happens in Washington. Simone caught me doing what I do every day, which I think about Memphis. I don't have the ability to think about anything beyond Memphis. So, so I see around me, people that just bring love into the mix in so many powerful ways. And I just try to put a straw in them and realize that we need each other at every turn. So I live every day with enormous hope, because I know tomorrow I'm going to see it again.
Sam, what about you? Where do you find the hope?
So the church I attend now virtually in Dallas, the first few weeks of COVID, the minister's sermons, the first one was a lot about everything that was being canceled. But one thing he said, one sermon was faith is not canceled, was 1 week. And the second week was that hope is not canceled. Then the other thing I often refer to is Saint Augustine, or Saint Augustine of Hippo. He says hope has two beautiful daughters, courage and anger. And anger at the way things are, but courage to do something about it, to act. So what I see, whether it's these conversations, or I just see people who have found their way in the midst of COVID, that gives me hope that they have found purpose in the midst of COVID. And that also is a sign of hope. So we just have to look around us, and there are things right before us that say, God is still here. God is still working. God is still blessing. And that's what our hope is built on. We have the song, my hope is built on nothing less than Jesus Christ. So that's where hope comes from for me.
Thank you, Sam. Sister Simone, where do you see the hope?
Well, I mean, I have to do this plug. I have a book coming out next month, and it's called Hunger for Hope. And what it's about is actually a contemplative prayer practice grounded in community and applying it to social engagement. And it really is based on my visceral experience that we are one body. And from Paul's teaching that as one body, we all have a part to play. And I have to do my part. It was really what you were saying, Sarah, to do, well, actually each of you, Scott and Sam were saying it too. Each of us does our part. And what I've come to realize in my prayer is that my role in the body of Christ at this moment is to be stomach acid. Too often we think of it in really, state, I'm an arm or I'm a leg, I'm a hand. No, I'm stomach acid because I go around and I interrupt people like Scott about, no, it's not just about Memphis, it's about everybody else. And I, lobby on Capitol Hill but what I don't do is the direct service that you're doing, Sarah, or you, Scott, or you, Sam. And I rely on being connected with you so that my stirring up energy to help make change can then fuel you to carry your piece forward. And to see ourselves in community is the place where we know we're not alone. And often I think when we get afraid that God's missing in action, periodically my prayer is, where are you? What I've come to realize is God's so close in that moment. God's too close to be seen. And so that our challenge is to be connected with each other so that we know God's right here. My experience is God hums us at every moment. God creates me at every moment. We're never forgotten. We might screw up. Yeah, we can do that. But we're together, and that's how we move forward. I do want to say one thing that's been in the chat. There's a whole bunch of parish nurses or church nurses here. I want to call them out as being the front line of trying something new. And I have to confess, when I first heard about it about 20 years ago, I was like, church nurses? What are that? And then my mom got sick. And it was one of the most graced gifts to her to have both the pastoral ministry and the practical nursing to come together. So maybe we are on the cutting edge. Maybe that's how we'll move forward. But we'll do it if we're one body and we move together. So just do your part. Trust God's in the midst of this. Make it mischief. It'll be cool.
Thank you, Sister Simone. And we've actually gone a little overtime. I hope, but our people have been staying with us. So I thought, well, if they've got time, we'll keep going for a few minutes. But you really said at the beginning that money has become this measure of winning. And I think Faith and Finance's part in the whole is that we want to be a voice that keeps reminding this conversation that money is not the measure of winning, that it is following the path of Jesus is the measure of winning. And we want to invite all of you to join us on that path and in that conversation. Everybody on this listening in is going to get a survey form, and sometime in the next day or two, asking for some information about how you heard about this, and also giving information about our upcoming events. Now, neighborhood economics, this conversation would have been just as important at our neighborhood economics event as it was here as a standalone. And I really cannot thank you each enough for the contribution you've made. And I think from the feedback we've been getting, every one of you needs to expect that we're going to invite you to do something again, because the responses to each of you, what you said in the chat and through text messages from friends who have been texting me what they think as we go along, has been really exciting. We do have that event coming up on October the 8th, where we're going to be talking about how can the church make sure its crisis in economics doesn't get in the way of mission. And then the next conversation will be about how does the church become an anchor institution in the neighborhood? Because we know that 2 weeks after this election, whoever wins or loses, or even if we don't know 2 weeks after the election who has won or lost, that people are going to be deeply hurting in our neighborhoods. And how do we respond to that through our faith? And so I just want to thank you all for being with us, and look forward to talking to you again. I feel like I've made 4 new friends, so
You have.
thank you for joining us, and we'll see you all soon.
Thank you.
Thank you.
God bless.
God bless.